going on in Washington. And then we would turn in the second half of the program to look at local issues that actually antedated the national program in health reform. And those are activities going on in the south side of Chicago, related, many of them, to our own hospital at the University of Chicago. We've assembled a panel. You see them in front of you. Stacy Lindau is to your left, and Harold Pollack is in the middle, and Eric Whitaker to your right. And I will briefly introduce Stacy, and then, well, maybe I'll introduce all three panelists so that we can actually move through the program, which I'm looking forward to. Stacy Lindau, I would have said 5 minutes ago, is an assistant professor of obstetrics and gynecology, as well as medicine and geriatrics at the University of Chicago. But I did learn in the past 5 minutes that Stacy was promoted to associate professor. And I'm delighted to announce that. Maybe the first public announcement. Stacy has studied life course sexuality at the population level, and how sexuality is affected by illness and aging. In this regard, she's co-principal investigator of the National Social Life, Health, and Aging Project, the first comprehensive survey of sexual attitudes, behaviors, and problems among older adults in the United States. The focus for today's meeting is that Stacy Lindau is also the principal investigator on the Southside Health and Vitality Studies. The Southside Health and Vitality Studies is a program that aims to gather information that contributes to a more complete and deeper understanding of the factors that affect health and wellness in residents in our neighborhood on Chicago's South Side. And so in this panel, Stacy will speak first, and she will be speaking about the Southside Health and Vitality work that she's been doing. The second speaker will be Harold Pollack, a professor at the School of Social Service Administration and the faculty chair of the Center for Health Administration Studies. Harold has published widely on the interface between poverty policy and public health, research concerns on questions like HIV and hepatitis prevention for IV drug users, work on drug abuse, issues of infant mortality prevention. He's published in major medical and public health journals. He sits on committees at the National Academy of Sciences Institute of Medicine. He holds master's and doctorate degrees in public policy from the Kennedy School of Government at Harvard. I think, Harold, you also write that blog for the New Republic, do you know? A web column, excuse me, web column on health and health policy. And our third speaker in the panel, Harold's topic is going to be health reform and urban health. What can we realistically expect from likely reforms? And the third speaker will be Eric Whitaker, who's the Executive Vice President of Strategic Affiliations and the Associate Dean of Community-Based Research. He's responsible for the Urban Health Initiative, which links the medical center's mission in patient care and teaching and research with the commitment to improve the health of Southside residents. Prior to coming to the university, or I should really say prior to returning to the university, Dr. Whitaker served as director of the Illinois Department of Public Health, and in this capacity, he oversaw a huge agency with a budget of about $500 million a year, and more than 1,200 employees. He had previously, prior to that, been an attending physician at Cook County, and we remember Eric because he was also a medical student and a Robert Wood Johnson clinical scholar with us. So it's wonderful to have this panel. Eric's topic is going to be local initiatives to improve health care. So we're going to start with Dr. Stacy Lindau. Stacy, welcome.
Okay, well, good afternoon. I want to thank the MacLean family for their continued support of this excellent conference, and a special thank you to Mark, who invited me to participate and who's been an unwavering colleague and mentor for my entire career at the University of Chicago. Thank you, Mark. So I've been asked to speak today on the topic of health justice for the South Side of Chicago from the perspective of a researcher interested in what science can possibly do for the cause of justice. In the last week, my perspective has expanded unexpectedly from that of a researcher to include that of an activist on the topic of health reform, and I'm even further emboldened by the conversation that preceded this session. Perhaps during the question session you want to hear more about my plans to go to Washington on December 10th with at least 20 physicians from across the United States to voice a principled argument about what our senators should do with respect to health reform. But that's another story, and I'll leave it only if you're interested. So time is short, and I know you're eager to hear the brilliant speakers who follow. So I'll start by stating the 3 points I hope to communicate, and I'll make my case with a focus on the South Side of Chicago. So 3 points. First of all, health justice, in my view, is not an aspiration, and it's not a goal. It's a means to an end, the end being that all people living on the South Side of Chicago can choose the pursuit of health and can choose healing in the face of illness or suffering. Number 2, science can happen in service to community priorities. And 3, science in service to communities promotes health justice through meaningful, asset-based engagement with the community. So welcome to the peaceable kingdom, and here we go. Before I go a bit deeper with each of these points, I want to introduce you to the South Side of Chicago. Of course, some of you are very familiar. Here you are, you can see on the map in the region of Hyde Park, Area 41, which is just where we're now, immediately adjacent to a neighborhood called Woodlawn, where we're doing quite a bit of work at the invitation of organizers in the community of Woodlawn. South Side of Chicago and the University of Chicago have a long history together, and the university has clearly had an important historical, intellectual, cultural, powerful force in our community with roots going back to the 19th century. The South Side of Chicago, defined for the purposes of the South Side Health and Vitality Studies, encompasses a geographic region including more than 1.1 million people. I heard a talk last week from Mitch Katz, who's the director of the Department of Public Health for the city of San Francisco, and our region was bigger than the population served by his Department of Health. The vast majority of people living on the South Side of Chicago are African American. As you can see in the table, 72% of the residents self-identify as African American as compared to 35% in Chicago and 12% in the United States. And this is one of the unique features of the South Side of Chicago. This area is known for its rich cultural history, a strong tradition of community organizing that has helped produce some of the nation's, if not the world's, most powerful community leaders. And as I've been learning firsthand over the last several years working here, there is a tremendous, strong, and enviable web of social network that links residents and community organizers and civic leaders together in this region. The region is racially homogeneous, and here you see a map of the city of Chicago where the dark blue represents the population, communities where the population is 78 to 98% African American. The light blue would be areas where the population is 0 to 7% African American. And so this represents a racial divide, a stereotypical racial divide or segregation that characterizes the city of Chicago. So how does the city look socioeconomically? Does it divide along these same lines? And what we see actually when we look at percent of households with annual income less than $25,000, not necessarily the same pattern. Of course, there is a concentration of communities immediately surrounding Hyde Park, and I have a pointer here, so here's Hyde Park, and then we're surrounded by a ring of communities where 48 to 65% of the households have an annual income less than $25,000. But when we look block by block in this region, we actually see more heterogeneity, where some of the wealthiest individuals live within houses or even a couple of streets of people living with the very least. These characteristics of the South Side create an opportunity to understand how, within the African American community and across the socioeconomic spectrum of African American people, non-medical factors influence health, social determinants of health. How literally do factors and conditions outside the body penetrate the body to promote health or trigger disease? Why do some individuals living in the same environment seem to deflect the potentially damaging factors, while others easily absorb and succumb to them? This is a question about resilience and one that interests many of us, and it's one of the interesting things we can uniquely learn by doing research on the South Side of Chicago. These are just some of the features that have attracted social scientists to the South Side, and which has become known as the laboratory for the Chicago Schools of Sociology and Economics. And my work so far with the South Side of Chicago would indicate that some folks living in the South Side communities, particularly those who are immediate neighbors in these much poorer communities, feel like they live in our laboratory. It's a place where we go to study and learn what can help someone else somewhere else. We go in with our bright lights and our microscopes, and when we're done, we turn off the lights and walk away, and folks don't get back what we learned. In this case, with the Southside Health and Vitality Studies, we're doing something different. We regard the community not as our laboratory, but as a wellspring of ideas, questions, and expertise that gives life to and synergizes with our own technical skills as scientists. Working with our community opens the possibility that what we discover can have impact that we can actually see, and that can bring us into solidarity with our patients and neighbors. This is a new way of thinking about the South Side that I believe has unleashed some pent-up energy among faculty who share a passion for social justice, but have struggled to find in a complex care system a local outlet. This is also representative of a new way that academic medical centers around the country are thinking about their communities. We're not entirely unique here, and there are many reasons that prompt us to rethink our relationship as an academic medical center or as a university with our community at this point in time. I imagine some of the comments of Eric and Harold will enlighten that. From the perspective of research, it's a major shift in the way that the National Institutes of Health is now funding academic medical research that has had a very important influence. So let's turn back to the 3 points. First of all, health justice is a means to an end, the end being that all people living on the South Side of Chicago can choose the pursuit of health and can choose healing in the face of illness or suffering. Now, I have to say, as a gynecologist, I hesitate to even talk about the concept of justice in the halls of the law school at the University of Chicago. But I will just say that I take a simple-minded view of what it means for the purpose of this discussion. It's a term whose etymology dates surprisingly only to the 12th century, Middle English. Certainly many brilliant people have attempted to define it, but Merriam-Webster's 2B definition puts it like this: it's the principle or ideal of right action, or doing the right thing. So we also know, of course, that justice is one of the 3 pillars of medical ethics. And it motivates our obligation not only to concern for the individual patient, but even more so our obligation to society. So at this point in the life of the Southside Health and Vitality Studies, justice has been defined in terms of the equitable partnership needed to jointly carry out actionable health research in the community. And you see this here reflected in some of the images of our growing collaboration with the community. So this are pictures from a retreat, our second retreat that we held at the DuSable Museum of African American History just a couple weeks ago. We had over 120 participants, half community, half university folks. And here's another image of students, university students, paired with community residents who have been working on 6 communities on the south side, mapping every built resource, every establishment that wasn't a private home, into a system that's now available only a couple months later on the internet, available to everybody. The other way in which justice is reflected is through a set of shared principles that have been iterated over time in collaboration between university researchers and community folks who've come to the table with us repeatedly. So the goals or the principles are around collaboration, mutual respect, and shared benefit. And without reading them all, let me just highlight a few. So we have a principle to build mutual respect and trust between the researchers and community members. We have among our principles to maximize participation of and leadership by people living in our target communities who have a particularly important voice in shaping our work. And we have a principle of creating learning opportunities by involving students, trainees, and community members. These have been iterated, as I said, time and time again. Finally, I think have stuck long enough that we accept them as the principles of our work. Urgent action needed is the mantra, and the notion of not acting with respect to health reform or solving some of the most important healthcare problems is one that certainly would not be tolerated by, I think, either our community members or the faculty involved. So the second point is that science can happen in service to community priorities, and frankly, this is a claim about a mercenary role for science. In one setting, we were asked how science in service to community priorities was different from science in service to the pharmaceutical industry. And this got us going, and frankly, I think it raises some interesting points that we can discuss later. For now, I want to argue that science that happens in service is no less good than science that emanates from the fascinations, passions, and curiosity of the mind of scholars. In fact, the primacy of patient welfare among our professional principles translated to physician-led research would suggest that science, like clinical practice, be motivated first in service to our patients, altruistic science, before we pursue science in service to our own self-interest. I would submit that the most critical questions in science, even the most basic of scientific inquiries, come from unanswered questions asked by our patients or impenetrable problems, pandemics, plagues that baffle our communities and outwit us. Science to service in communities requires trust, transparency, accountability, commitment, and reciprocity. So as we've attempted to build these things, I just want to share 2 pieces about trust. And so as we've come to the table and engaging community members around research, we've had to overtly and proactively articulate it, what's in it for us. So we don't wait for folks to ask this question, we offer it as we engage. So there are a number of reasons why the university might want to engage with community members in prioritizing investments in research. A healthy and vital community is good for the university spirit, reputation, and brand. Maybe it improves our reputation and trust with our neighbors. Maybe it gives us an outlet for pent-up social justice passion. Maybe it allows us to compete for NIH funding that values community partner research. Maybe it allows us to publish papers and build our career. We then ask community folks, what's in it for you? And we haven't fully articulated that, but in many ways, these points resonate with community folks representing their own organizations, and coming to that understanding has been an important ingredient in building trust. Another piece is that the studies have been designed to generate new knowledge and be a training ground for researchers. So in asking our study participants whether they'd also be willing to be subjects of our research, we've needed to inform folks that when we meet, others might be observing. We might have reporters, we might have ethnographers, we might have researchers studying what we're doing. And so we engage by reminding people that our work is happening in a public forum, and by reminding them that we expect to be transparent and democratic in our sharing of the information we collect. There are a number of key ideas and themes that have come together around the research, and it's somewhat uncomfortable as a researcher to give a talk about the studies and not have told you what the 3 specific aims are, but frankly, we're not there yet. We're still defining those in partnership with our community members. So the third point is that science in service to communities promotes justice through meaningful asset-based engagement with the community. And the Southside Health and Vitality Studies are taking an asset-based approach to study design and data collection. We're approaching the study of community resources, health, human and social services, health systems, and even individuals from the perspective of what each brings to the table. So when we go and knock on doors and ask people to participate in our survey research, rather than focusing on deficits or illnesses, we might focus first on what are your strengths, what's your special expertise, what do you bring to the table in helping us solve some of the problems with respect to health in our communities? How can we leverage these strengths? What are the most influential points of intervention to promote health, reduce suffering, and realize full vitality of the community? So a number of key ideas and themes have come out, and repeatedly so, and these are shaping how we'll ask and what kinds of questions we'll ask. And again, I won't read them all, but just to highlight a few, there's a sense that health happens largely outside of medical care. It happens at home and in the community. Health begins in utero, begins in early life, and has impact throughout the life course. That community academic partnership is a promising way to solve previously impenetrable problems in health and healthcare. And that we might, in our work, focus more on health at the community, population, and systems levels and assets of individuals rather than trying to develop interventions that change individual behavior. That research is important, just not the first priority of the group at the table. And so we don't have specific aims, but at this point, I think what we can say is we have principal aims, pun intended, informed by the shared sense of where we should be going. Number one, that scientific inquiry and the investments we make in research on the south side of Chicago should be in service to community priorities about health. Number two, that we need to build an infrastructure that can bear the weight of this complex collaboration in solving health problems, and that we ought to create lasting jobs and new careers for community folks who want to endeavor with us in this work. And then thirdly, of course, generating new knowledge is very important. We want to generate knowledge that gives people free and open access as much as we can while protecting individual privacy and confidentiality. That we ought to generate knowledge that has measurable impact on the health of the community and knowledge that's translatable beyond the south side of Chicago. So in closure, I have to say, in comparison to the prior set of speakers, I feel that I've probably just raised more questions than I've actually imparted new knowledge to this group. But it's an honest reflection of where we are with the Southside Health and Vitality Studies, and I want to thank you for giving me an opportunity to share with you this work. Yes.
Thank you very much. I think we'll take 2 or 3 clarifying questions for Stacy before we move on to Harold. I'm going to ask the first one, and that is whether the kind of work you're doing on the South Side is work that's been done in other urban areas. And so our specification is to do it on the South Side, or whether that's a new body of work.
I think the answer is a combination. So one of our major investments has been in resource mapping of the community. Literally, the first round of which is training people to walk up and down the streets with PDA-like devices and enter every physical establishment in the community, place-based mapping. This has certainly been done before. I think what's novel about what we're doing is that we've taken a community-partnered approach to designing that data collection and prioritizing it. We also, within 3 months of collecting the data, made it available on a website that's open to everybody. Now, and the interesting piece about that is, we're used to, as academics, not putting something out there until it's finished. Well, in this case, we had to do something that we're not fully comfortable with, which is putting it up there raw. So it's early enough that community folks could then be invited to the table. That was it went up October 13th, the retreat was October 14th, and the website was the basis for engagement and conversation at the retreat, where folks could see what was done, but it was early enough in its development that they could have a real role in shaping where it goes. So I think that's a unique piece. said in response to both questions. But first of all, I would say that we're, in addition, so the way we started was through a social network mechanism. You know, who do we know? Who's already collaborating with the university? Who can kind of be our shepherds, so to speak, or Sherpas? A variety of metaphors have been used into a variety of communities. So we've been engaging with individuals, community-based organizations of all kinds, faith leaders, and we have met to some degree with the business community. We've been to the Chicago Chamber of Commerce. Many of the folks who've come to the table and have had time to come to the table, frankly, are business leaders. And so there's a deliberate effort to think about those entities. I also want to mention that aside from the resource mapping project, which has been a major investment of institutional funds with which I've been entrusted, we have conducted something called a recruitment and retention study. It doesn't have a glamorous name, and we haven't had as much community engagement in that project as we would have liked, but the intention there was to think about who will be the folks who will be the hardest to reach or the hardest to include and engage and follow over time if we were to do an individual level study. And for example, folks living in single rent or occupied units are people who oftentimes are not included in population-based research because they're just difficult to for us to access using the traditional methods. So we've been working with the recruitment intention study and offering people access to texting and unlimited texting and cell phone technology as a way of keeping in touch with us and finding folks really willing to engage when we give them a way of staying involved. So thank you for the questions. Yep.
Thank you. And there will be time for more questions during the question and answer session at the end. Harold Pollack will be our next speaker on health reform and urban health. What can we realistically expect from likely reforms? Harold, please.
I should say, just before we start, a few things. One is, since we are at the MacLean Center, and thank you so much for inviting me today and for the chance to listen to some really terrific speakers. I think the ethical dimension that Dan Brock mentioned is one that's so important, and we start, every time we've tried a major health reform, we start with a real focus on 50 million people nearly who don't have health coverage and millions more who have significant health issues. And then as the debate proceeds and we get down into the boiler room of national insurance exchanges and the technicalities that need to be attended to, we often lose that human face. And I think it's here on the south side of Chicago, it's especially important not to do that. And a part of my life that Mark didn't mention is that I'm the guardian of a mentally and physically challenged man who's a Medicaid recipient, and we actually use the Medicaid offices and the tender administrations of the welfare office here, and we're very grateful actually for some excellent medical care that we receive at the University of Chicago Hospital. And living with him and seeing what he goes through and seeing what his friends go through, who have $50 a month for everything from a hamburger to a pair of pants, who live in group homes that are staffed by men and women who work at near the minimum wage and who themselves are often uninsured. It is really striking to me, and it's one of the things that's most striking to me is that in many ways the health sector is the one where we're the most egalitarian in our society. I'm the co-director of the University of Chicago Crime Lab, and I spend a lot of time in some of the neighborhoods that Stacy put up on the map. And actually the medical clinics that people will go, they will wait, but they will receive proficient care that is often quite good. When they go down to their local school or their local welfare office, or they call 911 to get help, in general, I would say they do not get the quality of care and attention and human contact that they'll get at that local health clinic. And that's true even if they're uninsured. And one of the ironies is that because so many of the health challenges that men and women in these communities face come from outside of the health sector, our very targeted sense of egalitarianism that centers around health ends up being self-defeating. And a lot of these men and women come into the health system with significant problems that come out of the social domain that we do not deal with very effectively. So by the way, I should say, pardon me, I'm still in recovery from Richard's presentation. I actually think one of the great things about teaching at the University of Chicago is that you can come and listen to such a terrific talk by someone that you totally disagree with, but have to go home and figure out, now, why is it that I'm so irate at that? But I want to talk about the issue of health disparities. And I think there's two positions on health disparities that most people hold that are actually very seductive, and they're also polar opposites. One is that, we have all these, we should do health reform because we have all these glaring health disparities, and if we just catapulted insurance cards at everybody, we would get rid of all our health disparities, and we would have the same kind of infant mortality rates that they do in Norway. That's one view. And of course, the other view is, it's all social determinants, and there's a sort of faux sophistication that comes from saying, most of the real problems that we have in the south side of Chicago have nothing to do with the health system. It's kind of rewind the tape to what I said 5 minutes ago. Why are you giving people health insurance cards? Why not give them a good school? Why not give them X, Y, or Z? Some money would be nice. And I think both of these views have an element of truth, but they both also are a little bit lazy and oversimplified. Because I think there actually is reason to think that health reform won't do as much as we hope it will do, but it will do some things that are important. All right, Mark, will you clue me in when I have 5 minutes to go? So first of all, why is the naive optimism wrong? I think one way to see why that's wrong is to think about this very simple slide. Suppose that we say we want to improve people's health by getting them financial access to insurance. Well, if you think about what's the causal chain here that we have to go through. So first thing is we give people financial access to insurance, and we assume that will actually increase the number of people who have insurance. Given that, we assume that people will use health services and that will improve their health. By the way, I could, of course, have added a lot more boxes to this causal chain, but this is quite enough. Every single arrow here is contestable. And moreover, if your goal is to get down here, it's not at all clear that this would be the obvious pipeline that you would necessarily want to use. So it's, if you think about, what is it that we're likely to accomplish in the 2009 reforms? This is a somewhat abstract. Think of this as something you'd see in the Art Institute. This is 2,000 pages put in elliptical fashion. Now, a lot of people think, okay, what that really is it's universal coverage. But of course, it's actually not. We'll have a significant number of people who are not going to be covered, some of whom are because they're unauthorized immigrants in the United States, some of whom because they're young and healthy people who would prefer to pay the penalties for not being insured, and some for other reasons. Now, if we achieve universal coverage, that's not at all the same as improving the care that people receive. And since the expertise in the previous panel certainly dwarfs mine, I won't say a lot more about that, except that that's important. And of course, even if we achieved optimal health care delivery for individuals, there's this thing called society out there that would matter in terms of improving population health. In the neighborhoods that I work in, basically non-Hispanic whites have the same homicide rates that people do in big European cities, and African-American young men have maybe 30 or 40 times that homicide rate. There's nothing that we're going to do in health reform that's directly going to fix that. So there's clearly a lot going on that is not being captured by the inside of this diagram. And I think that's the truth in the sort of cynical perspective about disparities. Interestingly enough, by the way, from that perspective, the really important thing about health reform is it's generating economic resources for poor and middle-income people. And that's what we're going to do that's really valuable. I'll just mention a couple of things. I don't think there's anything interesting on this slide, so I'll just hit the space bar. One thing that's really important, and it gets in a way to a point that Jim Madeira talked about briefly at the beginning, there's a lot of attention paid in the disparities literature to the interpersonal interactions between doctors and patients. And are doctors able to take care of, say, low-income African-American patients well? That's an important issue of cultural competence and so on. I think the more we learn in the health services literature about disparity, the more we're learning that it's where you get your care. It's not so much that the doctor treats black patients worse than white patients, but you're in a different hospital that doesn't treat any patients as well as, say, a high-quality unit should. So if you look at, and Dr. Chandra at the Kennedy School has already been mentioned once, he's done some very interesting studies of heart attack, showing that white heart attack patients and black heart attack patients get their care at very different hospitals, at very different levels of technical proficiency. And the same is true in natal intensive care and in other ways. Right now I'm trying to find a dentist who is willing to take the Medicaid reimbursement rate and who also can take care of a 250-pound mentally disabled man. I think it's going to be hard for me to find someone who's going to give the quality, the technically proficient care that I would have if I had the same dental problem. So one of the challenges for health reform is, can we change where people get their care or improve where people get their care? And that's very pronounced on the South Side here. So now, what are some reasons to think, hey, health reform actually does matter? Well, first of all, there's a very indirect effect that health reform serves. And I think one of the most important things here in Illinois is health reform might help shore up the finances of state and local government. One of the ironies about health care is the cost of health care is just killing state and local governments right now. We see this in Illinois very profoundly. There's 47 states that are in fiscal difficulty, and Medicaid cost growth is one of the 3 or 4 major drivers of that. And part of the function of health reform is not to change the way individuals experience health care, but to create a stable financing structure so that everything else we're trying to do in education and law enforcement and so on can actually be done. The Senate and the House bills handle these issues in different ways. In general, the House bill pays more careful attention to relieving the burdens on state governments. One of the real temptations that federal policymakers have would be to dump the burden on states like Illinois for a lot of expanded health coverage. Protection against high out-of-pocket costs and medical bankruptcy. I should mention this because when I moved here from the yuppie paradise of Ann Arbor, Michigan, and one of the things that I saw moving around the South Side, which I hadn't really seen before in Ann Arbor, were signs at bakeries and little diners for bake sales that people were having because a relative was having a kidney transplant, or I guess kidney would be a bad example, but a liver transplant or some other very costly procedure, and the family was raising money for them. One of the good things about both the Senate and House bills is that to a significant degree, they can protect people against catastrophic medical expenses. And whatever critiques one would have of that legislation, it is really striking that the United States is a place where people can get cancer and lose their house in a way that does not happen in other wealthy democracies to the same extent. And we certainly, if you go down to the collection agency of our hospital, you will see a lot of stories that are, or go down to the Cook County courthouse. I recommend to anyone, has anyone here read Jonathan Cohn's book, Sick? It has a chapter where he went down to the courthouse and he just looked at all the bankruptcy cases, many of which involved health care, one of which involved, by the way, a Catholic health system suing a retired nun who was so poor that her job was to work for Meals on Wheels, and they would bring 2 meals, one for the person she fed and one for her. And she ended up in the emergency room, and she got a $700 bill she couldn't pay, and she ended up in the courthouse. Just to give you a sense of, I don't have time to describe this quickly, but this is what's in the current House bill. Really, I think that's one thing that we can say. There's a lot of people in this area who would benefit greatly from the subsidies that they would get from these bills, and also from the limits on out-of-pocket expenses should they become very ill. The Senate bill is actually less effective, and is actually and I'm a little concerned about that. 5 minutes, okay. Although the Senate bill actually is more ambitious in delivery reform. Now let me skip up a little bit then to disparities. By the way, we talked a lot about primary care. I don't know if you can read this. This is a cartoon from the New Yorker. It says, "This man's a wonderful primary care husband." And here's another one that's actually more appropriate, if I could This one says, is there a doctor who accepts Medicaid in the house? One of the most important things for Illinois is a provision that nobody particularly is paying attention to in the House bill that would raise Medicaid reimbursement rates for primary care eventually up to parity with Medicare. Right now, Illinois pays about half. Now, there's a real question which we discussed earlier today. Will it be enough so that people go into primary care to raise reimbursement rates? I do not know. But right now, places like the University of Chicago Hospital lose so much money on Medicaid patients and then are berated by the public and politicians for not being as nice to those patients as ideally we would be. These are really important provisions. Let me speak finally to the health impact, because I think that's really substantial. No one exactly knows what the impact of expanded coverage will be on health disparities, but we have two good sources of information. One is the old 1970s Rand health insurance experiment, and the second is what happens to people's health status and to disparities when you look at 60 to 64-year-olds and you look at people who are over the age of 65. Now, there's no really good research on the predicted mortality effect of insurance coverage. I don't think that we know for sure. The Institute of Medicine says 18,000 people die every year because they're not insured. I think that is 18,000 plus or minus a lot. The Rand health insurance experiment predicted that the mortality rate among people with high cost-sharing plans relative to low cost-sharing plans the difference was about 38%. It was mainly among low-income people, and it mainly came from one thing, which was hypertension. Turns out if you bump your knee and you go to the doctor, your doctor may not be able to do anything about your knee and may charge you a lot to do something that's a laying on of hands, but they will take your blood pressure. And if you have hypertension, they will deal with it. And so the Rand health insurance experiment found that low-income people, when they were given good health insurance, were able to control their hypertension more effectively and some other similar things. And I think that's probably the one area where we can say it's really credible to think we're going to have a large population health impact if we can get people into primary care and get some of these basic things done better. By the way, just to preempt Richard, if they did that at Walmart, I'd be happy. Now let me show you something for Medicare. It's really striking how the disparities before people become Medicare eligible are really much greater than they are after the age of 65. We see this in blood pressure, which is really, the most important and preventable thing that's going on the south side of Chicago is not young men killing each other. It's people having a stroke and people having cardiovascular disease that is at profoundly high levels. And much of that is avoidable. And what you see is after age 65, much lower differences in blood pressure, black-white differences in glucose control come down, and you really see Medicare actually does accomplish a lot for people in reducing these basic disparities. This is not access to high-tech care, it's access to basic care. By the way, Medicare could be improved. I think we could do better than that. Similarly, if you look at things like preventive screenings, you see people get much more in the way of preventive screening after age 65 than before. Now, some of this is not due to Medicare, it's due to the fact that when you get to be age 65, all of a sudden your children are saying, hey, you're old, you got to go in and do this. But Medicare plays a substantial role. So I'm going to hazard a prediction about health reform, and then I'm going to stop, which is for places like the one south of this room, just a short bicycle ride from here. I think the 2009 reform will be both a historic achievement and a crushing disappointment at the same time. I feel totally confident making that prediction. I think the most important benefit will actually be economic in some ways. It turns out if you add up all of the money that's being transferred down the income distribution through the National Insurance Exchange, through expanded Medicaid, it's actually about twice the combined total of the Earned Income Tax Credit, which is the prominent cash transfer program we have, and all of our food assistance that we do at the federal level. So it's a $200 billion a year transfer to poor and working and middle-income people. And that's actually quite a remarkable accomplishment in a political system that's specifically designed to thwart large policy change and that shows such a tenuous commitment in so many ways to serving the disadvantaged. So I'd like to see us address the social determinants better, but I'm actually optimistic that we'll have something that that won't be everything that I want, but that will be a significant accomplishment. So I'll stop there. Thank you.
Harold, thank you so much. I think we're going to go right into Eric's talk, and then we'll bring Stacy back and have the panel up here. Eric is going to talk on local initiatives to improve health care. Eric.
Okay. Good afternoon. Of course, they have the newest version of PowerPoint here. Okay. First of all, I want to also, as the other speakers did, thank the MacLean family for their support of clinical medical ethics here at the University of Chicago. I enjoyed the previous speakers. Harold, I think you laid the table for me. And also Stacy Lindau, who is a collaborator and some would say a co-conspirator with me with some of my efforts around here. I also want to thank Dr. Mark Siegler, and he was my first attending when I was a third-year student, so he molded me in his own image. Though I have to tell you, I don't think I've shared this with you, Mark, and since we're with 200 of our closest friends. The summer before I started third year, I actually applied for the Clinical Medical Ethics Fellowship, and you told me I wasn't ready yet. And so 21 years later, I'm glad to be here to grace the stage and be involved with the Center for Clinical Ethics. So, I appreciated the discussion that Harold laid out, and that, we are trying to look at how we might change health. And I want to make a distinction between health and healthcare on the south side of Chicago, because we do get those two terms, and we use them interchangeably, and they are not the same things. In my view, the discussion that's happening in Washington is nice, but not sufficient for improving the health of the south side of Chicago. And we need to do that through creating an efficient system of health on the south side, doing some of the things that Stacy talked about in terms of creating science and service of the community, and also on the south side of Chicago, as I'm sure in a lot of places where academic health centers sit, overcome skepticism by the communities that surround these academic health centers. When I first started here about 2 years ago, I would often sit and actually stand in front of community audiences, and Jim Madera would sit in the audience as the dean and CEO of our medical school, and I would ask the question, how many of you all are skeptical of the University of Chicago? And it would dishearten them because I would raise my hand. Because, I'm from the south side of Chicago, and, I was born in Woodlawn. I practiced primary care medicine for 8 years, just immediately south of here, and started a Black Men's Health Center that still goes on today. And so have been a part of the town-gown relationship that is true at many academic institutions, with the relations between the academic health center and the community. So as we attempt to build a health system, as we attempt to do research, as we attempt to undertake projects that get beyond healthcare, we have to overcome that skepticism that's out there. And, and one of the things that, as Mark mentioned, I had something called the Urban Health Initiative, and really it is reorienting the work that we do on this campus to improve health with, or I should say, in collaboration with community, and get us off of this campus. One of the challenges is one of mindset for our faculty and staff in particular. They think that it can only be a University of Chicago endeavor if we stay within this campus. And through affiliations, we're now branching out and having relationships with a number of very qualified health entities, community-based organizations out on the south side. And, it should not surprise you that we have a lot of poor health here. If you look at things like heart failure, diabetes, renal failure, asthma, and bronchitis, and hypertension, and compare us in our primary service area, that map that Stacy showed you earlier, the 32 community areas, and compare us to the rest of Illinois, our rates far surpass those communities. And if you also look, the communities in red are within our primary care service area. Our rates of infant mortality are much higher than the rate of Chicago as a whole, or even more so than the Illinois average. So let us, since we're in the law school, stipulate we have poor health for the folks on the south side of Chicago. There's this woman you all may have heard of named Michelle Obama. She actually worked on a project that was out of our emergency room, where we tried to create medical homes for the 40% of patients who show up at our ED and don't have a regular doctor. This was done maybe 4 or 5 years ago. Actually, at the time, was lauded as something that was potentially a model across the country. And in fact, a lot of great news coverage. And importantly, people ended up getting connections that fundamentally changed their lives. Now, telescope this work and the things I built on this foundation some 4 or 5 years into a political situation, and our medical center became the devil, to put it bluntly. And in fact, there was much turmoil within the institution and without it on a national level, because many saw, they were trying to divine what the Obamas were doing at the national level and learn from the things we were doing here in Chicago. And the Chicago Tribune weighed in to say that the things we were doing in terms of connecting emergency room patients to medical homes actually ended up being a smart move and could be a model. And in fact, with the Urban Health Initiative, we are trying to create models for the country. I think I may have said this, but 70% of academic health centers reside in communities with poor health indices surrounding them. So, many communities don't get to partake in the excellent health and intellectual capital that exists on campuses. But I should say that, when you read about the Urban Health Initiative, this is just one element of the program. It's just one element dealing with the emergency room. In fact, we are trying to live up to this triangle of service, system, and science, and we're doing that through creation of, as earlier we heard from Stacy about the Southside Health and Vitality Study, which is about creating data that'll help guide policy and program development on the South Side, again, in collaboration with community. We also have, this is the work that Michelle Obama started, where she had 18 community health centers that came together to provide medical homes for patients coming out of the emergency room. This has now been expanded to include 25 community health centers, as well as 5 community hospitals. That's significant because now we have most of the healthcare players on the South Side around one table talking about quality, talking about access to specialty care, talking about actually how do we promote ourselves, because we did a survey right after I got here 2 years ago, and 65% of people don't know that community health centers exist on the South Side. And these are gyms that can be used as opposed to emergency rooms for primary care. And also, we are trying to do science in service. And we have, as Stacy mentioned, we did a mapping project. That data goes into a database, the southsidehealth.org, that's available for community members. And it pays homage to the idea that it does take more than having community health centers to have health, because you can look at food security, educational resources, other things that in fact improve health. And lastly, as we do research like the Southside Health and Vitality Study, we have a Center for Community Health and Vitality that we're in the midst of citing out in the community that will be a repository for data and translating that data into programs on a population base that we think will ultimately improve health. Now, all of this has happened within the last 2 years, so it is very early, and the story remains to be told. The results remain to be seen. But in terms of our goal, we're trying to create a replicable model, really focusing on primary prevention to prevent patients from getting diseases, and if they have them, manage chronic diseases, and in collaboration with community, extend our academic mission, namely patient care, research, and teaching, out into the community. And so we're excited that this has moved as far as it has in the last couple years. The cornerstone of the patient care portion is actually, again, trying to get a medical home. And why is that important? Because what we know from health services research is that if you have a medical home, you use less medications, you use the ED less, you get hospitalized less, you get more preventive services, all good things. So having a medical home is a good thing. And about a quarter of our patients who come to the emergency room don't have a medical home, and that's probably an underestimate because our Medicaid program here auto-assigns people, and oftentimes, even though there's an assigned medical home, people don't know those providers. And as I mentioned, we have a Southside Healthcare Collaborative. It's upwards of 30 providers, including community health centers and hospitals, and really, a gem of programs across the South Side. And in our emergency room, we use patient navigators who try to get people as they come through with low acuity illnesses connected to those community health centers, and they are arrayed across the entire South Side. We have upwards of 100 doctors that are in community health centers and hospitals on the South Side of Chicago. And one of the things that gets lost in the discussion about the Urban Health Initiative is, in fact, we do have an education mission as well as a research mission. We have the Pritzker Initiative where we fundamentally reshaped our medical school curriculum and for the first time have a community scholarship track that is embedded within the curriculum. And, as some of you all who have graduated from medical school know, I know at one point my wife and I, my wife is a physician, our educational loan debt surpassed our mortgage. And I just paid that off maybe 2 years ago. And so now through this program, the REACH program, we're paying about $40,000 a year for up to 4 years or $160,000 to allow our graduates to have the option of practicing on the South Side if they want to. And parenthetically, this is my son Caleb down there. He's a cute guy, isn't he? Yeah, I think so. I talked about the Center for Community Health and Vitality, and this gets to the point I think Harold was making, that having healthcare clinics, hospitals is sufficient, necessary but not sufficient. And we're looking at a public health approach that looks at education, looks at violence prevention, looks at economic development through the Center for Community Health and Vitality. The study that Stacy mentioned, the Southside Health and Vitality studies, will be based out of that, as well as workforce development. And in fact, we will have data there that will allow community-based organizations who need data for needs assessment and evaluation to come there to get the sort of skills, the data, and have the skills that we best possess to enable them to do the work that they do. So the vision over time, and again, we're early, is to have a virtual healthcare system with IT as the glue. As you've heard, there's probably up to $40 billion that will be spent on electronic health records, and we want to use that expenditure to the best use of connecting all of these health facilities on the South Side for both patient care and public health surveillance and research. We worked collaboratively with the City of Chicago on a $100 million broadband stimulus grant that we hope to hear the results of and someday soon. We've been waiting. We are organizing networks around different age populations and diseases for kids and pregnant women, for older adults, as well as for subspecialty care, like an HIV Center of Excellence that we're working to with the Providence Hospital, a public hospital nearby, to get online. And importantly, it typically is thought of in the community that academic researchers parachute in, get the data, and then parachute out, and you never hear from them again. And we're being very mindful through the work that Stacy's doing and through the Center for Community Health that we report out the information that we might find. And importantly, because the University of Chicago is the 4th leading producer of academic physicians in the country. To the extent we can teach the orthopedic surgeon or the radiologist about how community impacts health, no matter, if they're not going to be in primary care, but they'll be a teacher, it'll have a multiplier effect across this country. And so where do we currently stand in terms of our system? I talked about the Southside Healthcare Collaborative. It's nascent but developing. We also are in conversations with the public hospital that's about 1.5 miles away to create a relationship. In terms of service, I think we are moving nicely along in terms of the development of the programs of the Center for Community Health and Vitality. Science, Stacy shared with you the infrastructure that is being developed. And importantly, the trust has grown. So the sort of town gown issue that I mentioned earlier, I actually believe has lessened greatly over the last 18 months. In fact, there was one alderman who I visited to talk about research, and he started out the conversation talking about being guinea pigs, Tuskegee. He talked about all the things you expect to hear. And he came to the retreat that Stacy and her team led last week. And his comment was, this research, you all are taking too long. When are you going to get the data we need? And so it's been a total shift, because now that there's an understanding of how data can impact policy development and program development in the community. And I also think that, I started as a healthy skeptic, and in fact, Michelle Obama twisted my arm, frankly, to come. And she told me, she said, Eric, you have options. You can always leave. That if things aren't progressing, you can leave. And I've always taken that to heart. I'm still here, and I believe much progress has been made. And the asset mapping project is an example where we had a research need, and the community has a need for information, and we married those two and have come up with a spectacular product that others around the city would like to replicate. And in fact, Stacy and I were out in San Diego last week presenting at a national meeting, and there's a lot of interest in the work that we're doing here. Throughout this work, there's been all sorts of ethical issues that have arisen from to me, they're ethical. One, what is the role of a university? Should we care about community? In fact, I remember hearing a college president, several college presidents ago, who said something to the effect that we're here to educate people on this campus. We don't need to be out in the community. Other issues that come up have to do with trying to physicians who want to do a good job and feel a strong inclination to the patient in front of them, not understanding why we need to care about a system of care beyond our campus. In my view, and I come to this from public health, we see only 10% of the patients on the South Side. And to me, it raises the question, what about the 90% who aren't lucky enough to get through our door? How do we make sure that they have a quality system, the folks who don't get through the door, that's comparable to the ones that do make it through? And we continue to struggle with the individual ethic versus a community ethic. And there's many ethical questions that come up as we approach research and how to do it well. In fact, I think there's rich fodder for a whole year of symposia with the MacLean Center for the next year, which we'll be talking with Mark about soon. But with that, I would love to have some discussion and have enjoyed sharing what we're doing.
Fabulous. As the panel comes forward and sits down to take questions, I did want to make a brief announcement that when we're finished with the Q&A session, we're delighted to welcome you to a small cocktail party, share a glass of wine or a glass of club soda with us out front. Everybody, I hope, will be able to stop by for a moment and participate. Panel is open for questions. Let me just look around. Please. Okay, I think Martha, there's a mic right here. Good.
Okay. Martha Montello, University of Kansas. It's a question for Eric Whitaker. We were down in Kansas City appalled to read the I think it was 2 articles in the Wall Street Journal talking about turning away patients from your ER. How does that fit with the things you're talking about, the urban health initiative?
Okay, I got it. I mean, one of the fundamental challenges is trying to find truth, frankly. I remember talking with a Wall Street Journal reporter about our emergency room, and he said to me that we had closed 10 beds in our emergency room. And I said, we have not closed 10 beds in our emergency room. He said, yes, you have. And I'm like, well, I'm here. I know what we've done. We've not closed 10 beds. And I think one of the challenges was that we were in the midst of trying to deal with a couple problems. One is the fact that in our emergency room today, we have a number of patients who end up there who had just been in our hospital. So you're someone who has head and neck cancer, you're getting chemo and x-ray therapy, and you end up going home. You come to the hospital every other week, and so folks might have a fever and end up back in our emergency room. And what we found was that that these folks would end up coming to ED and being treated like they had never been to our hospital before, like they were new patients. Or another incident would be if someone had surgery and had left the hospital and then end up in our emergency room. So instead of calling the doctors who took care of them in the hospital, they would sit in our emergency room for hours. We wanted to take 10 beds in our ED and have those patients who we just released go into those beds. Now, our emergency room docs thought that that wasn't proper, that they needed to be treated as an undifferentiated patient, and as they showed up, be evaluated as though they had never been there. We disagreed on that. And I think that the challenge with all of this is that because Michelle Obama was here, a lot of issues that would have been normal faculty issues and discussions ended up being played out on a larger stage than they otherwise would. Because fundamentally, it was a faculty issue that was in the Wall Street Journal. That was a faculty discussion between our hospital administration and our faculty members. So, so getting to truth, in my view, was a challenge because I was here in the middle of it and I didn't recognize many of the things I read. And trying to spend a lot of time educating people about how things happen for real was a challenge because people weren't interested in that. They were interested in making salacious stories and having it tie back to the Obamas.
Thank you. Yes, sir. Turn on your mic, please.
I was interested in one of the reports you gave that in the 3 S's in your UHI development, that only one local physician has joined the system for service. And I wondered how many physicians are in the UHI practicing, not related to the university, and how many of those are Afro-Americans? And secondly, with your REACH program, we at the Georgetown Medical School developed a program similar to what you described, called the GEMS program, in which we try to get the Afro-American students from the inner city of Washington to educate and pay the service, as you do, with return that they would practice in the inner city. And that has been really a failure because the number of Afro-American students from the inner city go into the specialty divisions of medicine where they take their residency program similar to all the rest of our students.
Well, first I would argue that, I would hesitate to have the burden of care for the South Side be only on African Americans. The thing that's true that even the folks who we've gotten in the program are not African American to date. If we were to rely only on African Americans, just given the demography of medical school admissions and people who graduate, we would be in trouble. So I think what we want are people who are committed to social justice and and who want to care for the people there. And, I started a Black Men's Clinic, as I said, a couple blocks away from here, and our physicians there were all African-American men. And one of the questions I often got when I would go out to talk about it was, could this be replicated without African-American men? And my answer would often be that patients can tell the sound of the genuine in people. If you're the real deal and you want to be there and you want to care for them, it doesn't matter what race, ethnicity, or economic status you come from. And I think that's the goal we have in terms of our program.
Yes, Bob. Identify yourself.
Touch on a point that I had in my talk but eliminated only in the interest of time. There is this question about whether science and service to community is really science, and kind of the perturbations to the science that might occur if we let people we're studying in on the question. There's not a good deal of evidence in the literature, frankly, to support that, because the notion of community partnered or community engaged or community-based participatory research is relatively new. If there is, I may stand corrected, maybe there's certainly a possibility that someone in this room is more knowledgeable than I on that point. I think, frankly, we're looking at a 1.1 million person geographic region, and even if we had one, say, democratically identified representative of all 34 communities, the odds of any of those individuals actually being enrolled through a probability sampling scheme into our individual level study are extremely small, and even if they were, the effect it would have on the overall conclusion is also likely to be extremely small. I think we have to accept the possibility that engaging with community may have some impact on findings. I have heard community-based participatory researchers talk about the negotiating of the presentation of scientific results to the previous question about co-authoring. And that's where it does, for me, kind of make it legitimate to ask the question, how is science and service to community different than science and service to pharmaceutical industry? At what point is the science independent of potential bias? But I think there are ways to deal with those issues, and they're not important enough that we shouldn't endeavor to take this on.
Preston.
Teaching health centers, this idea of an academic health center. And having been at HRSA for a while, under the previous leadership, there was a very, very concerted effort to improve the quality of care through national performance measures and measuring outcomes in all community health centers across the country. So that health centers are not really what they used to be. They're really much higher quality, and they would argue they're quite behind the pieces of it's just one-stop shopping for health care. You're developing your community track. Have you thought about, are you using this whole network of 25 health centers? And is there a possibility of moving a substantial portion of your clinical education and your residency training into the community through this network that you're now developing as part of your
Thank you, Preston. It's been an interesting experience. As I showed that slide with our campus and all of our teaching. When I was a medical student here. We were on this campus, and there is a great deal of skepticism about the quality of care off our campus. And one of the things I had to, I joked with people at a meeting that, when I practiced in a community health center 2 blocks from here, I gained 150 IQ points just by walking across the midway, that somehow I became smarter. And the reality is, if you look at objective measures from Blue Cross Blue Shield and others, in fact, for primary care, those community health centers do better than we do on our campus. So we have an image of ourselves, and there's reality. And so so part of what I've been doing is trying to get people acclimated to the reality. And we are moving teaching out there, because one of the challenges for getting individuals to practice in the community or do research or be faculty out there is they don't know what's out there. They've never been out there. And to the extent that we've gotten students to go out there, they're seeing faculty who are having robust research opportunities out there and educational opportunities. And I think over time, we will end up having our docs who graduate from our medical center seed all of these community health centers, and it'll just be part of what people do. Now, we're a long way away from there, and this is already happening. I trained at San Francisco General Hospital, a public hospital where that was affiliated with a high-class academic institution, and our docs left there and they practice in community health centers. And so I think that's where we'll be in 10 or 15 years.
If I could just add to that question, I think another issue for community docs who are part of our developing system is intellectual isolation. And we had folks visit from University of Oklahoma, Tulsa, where they really are, I think, a model for a really successful network of community health centers that provide educational experiences. I mean, their medical school is really heavily built around that. So they, I think, made the point, and something that I've been thinking about from the research perspective is how important it is in terms of retaining excellent physicians in the community setting to create an intellectual network where they feel part of a scholarly group and can contribute intellectually. So that's something we've been thinking about and working on, to the point of me advocating to people's department chair, how do we get these folks, how do we make it so they can attend our grand rounds while they're still at the center? Can we get some teleconferencing? We have to use technology, I think, to solve some of those problems.
Harold.
I'm glad that you mentioned HRSA. There's an alphabet soup of agencies that many people in this audience haven't heard of, HRSA being one, that we have a $2.4 trillion medical economy, and yet when we had the stimulus package debate and there was a real effort by the public health community, actually it turns out community health centers did pretty well in the stimulus, because it happened that a key senator liked them. She wasn't that interested in substance abuse, so we didn't get any money for safety net services for substance abuse. There's a real need to rebalance priorities so that we are funding those essential pieces of the safety net that really are quite that are quite cost effective, but that have some very significant problems, quality being one, and that are usually neglected. And we basically talk about about health insurance reform, and we do not talk about those pieces.
I wanted to ask a question, since the government is particularly interested in encouraging community-based research, and I see Lainey Ross is sitting here, who's co-directing the CTSA. Is there a relationship between this effort at community research that Stacy and Eric are doing and let's say the CTSA project at the university?
I mean, I think I alluded to that in my talk. I think it cannot be underestimated, the impact that NIH's shift in funding for clinical research at academic medical centers has had on universities being incentivized to look to their local communities. So for those who aren't aware, the funding mechanism for clinical research was General Clinical Research Center, GCRC. And this is how academic medical centers funded clinical research for a long, long time. And then a few years ago, NIH made a shift to a Clinical Translational Science Award, required all academic medical centers to recompete for funding that would still be the engine of clinical research, but heavily emphasized or asked institutions to demonstrate how the research agenda, the dissemination and translation of research findings would relate to the community. And so University of Chicago was highly competitive and one of the first institutions to be awarded a CTSA grant, and therefore, in part, is one of the leaders, I think, in kind of making this shift. So it's not entirely altruistic, and it would be dishonest to say so. I think NIH's funding mechanism and the opportunity it presents, especially with big dollar amounts, does incentivize how academic medical centers do their business, and this was a very important influence.
Ron.
To what extent telehealth
Actually, we're learning a great deal from efforts that have been done in rural settings with telemedicine. We actually have a burgeoning partnership with the University of New Mexico, where there is a paucity of subspecialists. And so the University of New Mexico ends up, through telemedicine, help train up primary care doctors that are throughout the state. And they just completed an NIH study that showed that for people with hepatitis who they ended up having equal outcomes for these primary care doctors who were trained up with the academic health center's liver clinic. And so we actually will be an urban model that's replicating what they're doing in New Mexico on the south side of Chicago. In fact, they were just here yesterday working on an NIH grant.
I just wanted to add to that. Eric mentioned that one of the efforts of the Urban Health Initiative group, myself and Eric and others, has been to work with the city of Chicago with the Department of Information Technology, which went after $100 million stimulus funds to build desperately needed pipe for high-speed internet access to key areas in the city. South side of Chicago there's a divide, and the digital divide is perfectly emblemized by the racial divide, frankly, of the city of Chicago. The south side is a desert with respect to internet access. So if we were funded there, we would have an opportunity to have high-speed broadband to 5,000 households on the south side of Chicago, all the major community hubs, and the pipe would be built in such a way that the wires that pass through it would allow for video streaming and kind of the state-of-the-art technology, with the anticipation of telemedicine being an important way to deliver mental health services, for example, or for training up of community physicians. These medical use cases were really integral to the city's application to the federal government for this, to compete for this funding. So we don't know the status yet. We'll see.
Richard?
I was intrigued and I agreed with the diagram that you had with the 4 stages from Brownsville to health outcomes. The beginning of Eric's speech, the expression that healthcare and health are not the same thing. And so the two sorts of things I'm asking about. One is, can you explore where the missing links are? And secondly, can you explore at least state what you think to be the alternative chains that have to be taken into account so you can put the whole picture together?
Well, there's a number of things. I mean, I think that in the popular culture, we associate good health with access to high-quality tertiary health care. And we saw this, by the way, in the stimulus debate, where we couldn't get money for smoking cessation services, $300 million, but then NIH was given a very large amount of money for lung cancer research. And that sort of perfectly exemplified how our priorities are completely backwards. There's no doubt that the major threat to population health, let's just say it has never been the case that the major driver of health disparities in almost any society is differential access to health care. Differential access to resources, to basic public health services, is more important. I think that if I could, now health care is awfully important, so I don't want to denigrate the importance of that, but there's a lot of evidence that, for example, the quality of education has a dramatic impact on people's longevity, both in terms of their ability to earn money and to live in safer communities, and their ability to assimilate health information and lead a healthier lifestyle, in their ability to avoid stresses that have a harmful health impact. It always struck me, my wife worked in a liver transplant service and with Medicaid patients, and they would always give kids these wonderful services, and there was one child, she had 2 livers, and each time she was sent back to a housing project in Hartford where her relative had been shot, and everybody thought it was okay that she went back to the housing project that was a profound threat to her well-being, and they also thought it was okay that they were spending $500,000 on the liver.
Through the Urban Health Initiative, we're trying to get beyond the silos that typically exist. So in Stacy's effort, we have folks from the medical center, but we also have people from the Center on Race, from SSA, from the policy school, from physical sciences. And, I was commissioner of health of the state, and I would have loved to have had the Department of Education, Department of Justice, economic development, because oftentimes these things are siloed off. and there's different perspectives, but I think that by bringing all of those perspectives together, as we are through the Urban Health Initiative, hopefully we will impact this thing we call health.
I just wanted to add one caveat, one additional point to that. Arden Morris is a surgeon at the University of Michigan who was presenting her work at a conference last week where we were in San Diego. And one of the most striking findings with regard to her research on colon cancer and looking at colon cancer outcomes in African American men was that even among African American men who had health insurance, they had a higher probability of mortality and a lower uptake of chemotherapy. And she did qualitative research with folks, and what she learned was that it's not even that health care doesn't solve all the problems, but the disorganization and disrespect for individuals of our healthcare system was actually a barrier to people who had health insurance accepting care. They were people described feeling so angry about the confusion in the system, the lack of communication between doctors, the inefficiencies, the inability to continue their life in any way if they wanted to get treatment, that they just said, forget it, I'm not getting treatment. So it wasn't even, it's about trust, but it was also about anger. And I think that we have to take that very, very seriously, because if we offer everybody coverage or we offer everybody access, but we do it in such a way that is inefficient and disorganized and disrespectful, we've made no impact at all.
Michael.
Michael Massal, Pediatrics. I have one policy incentive question for Harold and one women's health question for Dr. Lindau. Harold, when you look at the analysis of incentives, you mentioned your family member who is in need of dental care who happens to be on Medicaid. And I think that even though there's concerns in the states about the budgets and the entitlements, the state will gladly pay when your family member has an abscess and must go to the ED and require emergency surgery rather than to do the preventive health care. And those insidious incentives really dominate the state Medicaid lines and the pathways and stuff like that. And in a concern for social justice, how can you at all get a handle on that?
Medicaid is such a challenge. I mean, I must say, I smile a little bit when I listen to some of the debate over the public option and this idea. People are going to be forced to accept Medicare rates for services. And then I think, boy, a lot of the Medicaid providers would love to be forced to accept Medicare rates. I think there's a real dilemma that politicians have a very strong incentive to do nice things that are very visible, and they have a really strong incentive to finance those nice things by skimping on the things that people can't see. And a lot of those Medicaid services are in the category of hard to observe for the average person. So just take an example at random. Suppose you covered all kids and you did something really nice, but you really didn't pay hospitals what they needed to get paid and so on. That's very tempting, and that happens all over the country. I think that we have to change the financing structure of Medicaid in a permanent way. The costs of Medicaid are actually not that bad in terms of the cost growth, but they're put on the states that can't pay them. And so we have to federalize more of this program implicitly or explicitly so that we can run it properly. That's something that's not going to happen in the current health reform because that makes this Congressional Budget Office numbers look worse. Unfortunately, CBO doesn't have to figure out the impact on the states of health reform. So you can imagine what incentive that creates. But I think it's a huge problem.
My women's health question is this, is that, you know, there is disproportionate women as caregivers taking care of both the younger and the elders taking care of the younger. And one of the things is historically things have been tied to employment and work outside the home, and hoping that there are community systems that will exist during the day. And my experience on the South Side with families with disabilities is women are caught in horrific traps. The grandmothers are taking care of children with cerebral palsy and have to take 3 buses to get somewhere, and young women taking care of children who are on a tracheostomy are stuck with not being able to get easily reasonable access to subspecialists. Can you comment how the Southside Vitality is really going to look at the supports for women?
You know, I think just a couple impressionistic responses to that. Obviously, as a gynecologist, I have a deep concern for the welfare of women, and the problems that you describe are multifactorial and deeply concerning. I certainly don't disagree with any point that you made. Just a couple anecdotes. You know, we presented our work to the Chicago Community Trust, and as we were going through some of the slides, I put a slide up showing the transportation, and we mapped, you know, we have a map of the transportation infrastructure, and overlaid on that the distribution of our federally qualified healthcare centers, public hospitals, et cetera. Well, what do we see? The north side has lots of clinics and hospitals, all placed nicely along transportation lines. And on the south side, we have not a disparate number of healthcare facilities, but totally disconnected from transportation. Well, that's a health problem. And when they saw that, they said, you know, we've been investing in some work that relates to transportation infrastructure on the south side. We really need to see this map before we build those lines. So, you know, I guess that's just one anecdote about how when we think about collecting data, how important it is to think about resource mapping, the physical resources of the community, the service-based resources, the individual assets in the community, and the systems level assets, and make sure we're laying those maps on top of each other before we go in with solutions that, you know, maybe solve one problem but exacerbate another. You know, that's one issue. The other anecdote I'll give you is Woodlawn, the community of Woodlawn, immediately adjacent to this building. I imagine most people living in Woodlawn have never stepped foot in this building, nor would they think to. There's no such resource, anything like this, in the community of Woodlawn, other than actually the Apostolic Church, which is a beautiful facility and where we have some of our meetings. But folks there have been organizing to be competitive for federal funding around a children's zone. Some of you may have heard of the Harlem Children's Zone. And a beautiful thing happened to the Southside Health and Vitality Studies, which was that we got a call from Woodlawn saying, hey, we're embarking on this endeavor. It's going to be a huge investment for folks and organizations in our community over the next few years. We'd like to invite you to the table. Essentially, they were engaging with us. We were the community, we were the outsiders there, and we'd like you to help us figure out how to maximize health of children in the community. Well, certainly we know if we invest in children and we have systems of daycare and other things, we're therefore investing in women and families who care for children. So, I really appreciate your question. Maybe you'll come work with us on those particular issues.
Thank you.
Thank you.
I just have a few quick announcements before we conclude. First, I particularly want to thank Barry and Marianne MacLean, who are with us today, for their ongoing support. The conference couldn't have happened without them, and it's also in memory of Barry's mom, Dorothy Jean MacLean, who was a great supporter of ours from the earliest days of the center. Barry chided me yesterday. He said, why did you start at 1 o'clock in the afternoon instead of starting the meeting at 7 o'clock in the morning? And I said, well, we are starting at 7:30 tomorrow, meaning Saturday morning. Breakfast at 7:30. The meeting will begin at 8 o'clock. Before we go out for a short cocktail hour and to celebrate and talk to one another, please join me in thanking Stacy and Harold and Eric. Fabulous.